The two most widely recognized times for attachment problems, though, are 0 to 6 months and 1 year to 5 years. Within that first 6-month time period, either the child learns to trust the caregivers, that they're going to feed them, clothe them, bathe them, keep them warm, or they don't. Now, within the first 5 years of life, even if a child has developed a positive attachment, 0 to 6 months, it can also be lost due to significant abuse and neglect. Children who do not form healthy attachments may develop emotional, behavioral, and physical problems. We talked about this some with post-traumatic stress disorder and trauma-related issues a moment ago. It's maybe doubly true for attachment problems. Children who do not form healthy attachments may live in an existence of fear and mistrust, especially of adults. I just had this question yesterday in the office. Well, excuse me, it was 2 days ago in the office. Well, they seem to get along fine with everybody but me. Why is that? And this is a family I've been working with for some time that actually is a little girl I was telling you about a moment ago that the caregiver told her about what happened to the significant family member. And she's actually been doing very well, and she's got a transference object going on right now, and that's the foster mom. Transference object is the person that the child forms a relationship with later after they have attachment problems. That person's usually the person who either gets all the anger later, or that's the only person that child would listen to. So the dad's asking me, well, she'll walk up to strangers and she's just fine. She'll even do what they ask her to do. She won't do anything I tell her to do or ask her to do. Part of it's because she doesn't trust him. Part of it is because she's been exposed to mostly female caregivers. She's learned to trust females primarily. So we talked about some things that he could do to develop that. But they do. They very often live in an existence of fear. Now, just real quickly about tantrums, it is critical that we distinguish between a fear-based tantrum and a manipulative tantrum. Most tantrums that I see with children, I would say most of them are manipulative. However, I had a sibling group a couple of years ago that one of the little girls would have 6-hour tantrums. Literally, no consoling her. No matter what the caregivers did, it took a lot of therapy to get her decreased on that tantrum time, because her tantrums were literally because she was afraid. She didn't understand what was happening. This particular child had very serious sexual abuse issues as well as attachment problems. She lived in constant fear of the world. Constant. I thought we would start with reactive attachment disorder because that's the one that most of us are familiar with. However, in the new DSM, the DSM-5, there is a new disorder called Disinhibited social engagement disorder. Basically, what the work group did here was they took the old diagnostic criterion out of the DSM-4 TR, and in that it had two specifiers. It said inhibited and uninhibited type. What they're basically saying now is that the actual reactive attachment disorder is pretty much the inhibited type, the old inhibited type, and the disinhibited social engagement disorder is the uninhibited type. And you'll see the difference in just a moment because there is a significant difference between these two disorders. Criterion A consistent pattern of inhibited, emotionally withdrawn behavior toward adult caregivers manifested by both of the following. The child rarely or minimally seeks comfort when distressed. The child rarely or minimally responds to comfort when distressed. How many of you have seen this? Very common occurrence in my office. hear this commonly from caregivers. They don't want to be, a lot of them don't want to be touched. Don't be near me. Some of this is that fear-trust issue. B, a persistent social and emotional disturbance characterized by at least two of the following: minimal social and emotional responsiveness to others, limited positive affect, and number 3, episodes of unexplained irritability, sadness, or fearfulness that are evident even during non-threatening interactions with adult caregivers. That was the little girl I was telling you about a moment ago that had the 6-hour tantrums. Sometimes it was just because she messed up on a drawing. Blown completely out of proportion. That child's one of the few that I actually had in that had a diagnosis of reactive attachment disorder. C, the child has experienced a pattern of extremes of insufficient care as evidenced by at least one of the following: social neglect or deprivation in the form of persistent lack of having basic emotional needs for comfort, stimulation, and affection met by caregiving adults. This is what I was talking about just a moment ago. If they don't get this, they will usually develop attachment problems. Repeated changes of primary caregivers that limit opportunities to form stable attachments. And I have here frequent changes in foster care. One of the things that moving children around that are prone to attachment problems can do, it can actually make the attachment problems worse. I have a young man in my office right now. He's 16. He has been moved around to, I believe, 10 different homes now. He doesn't get it anymore. He doesn't trust anyone. He doesn't trust, he's been adopted, but he's been actually removed by Child Protective Services at this point. He trusts himself, sort of, but he didn't really trust himself anymore. He doesn't trust his adoptive mothers. He doesn't trust the system at all in any way, shape, or form. He was just in an RTC, a residential treatment center, where he was actually doing very well until about 3 weeks ago, right after Thanksgiving, and he decided he was going to run. They kicked him out. Now we're struggling with what's going to happen with him next, because his adoptive family has already said because of his violent tendencies and behaviors, they don't want him back in the home. By the way, when we hear that the system has harmed the children, my experience has told me this is the way the system has harmed the children the most, is by not having permanent placements for them, having forever homes, and they get moved around so much. Does, I believe, honestly, more damage than anything else that occurs to them in the system, unless they are just repeatedly abused. Rearing in unusual settings that severely limit opportunities to form selective attachments. I'm sure everybody's heard of Mother Teresa, okay? One of the great things that Mother Teresa did was she went into orphanages in India and trained people on how to just touch the baby every day. Because until her intervention, babies were just put into these great big rooms and there was no interaction. A lot of those babies died because they had no interaction with the caregivers. After they started doing these types of things with the babies, the majority of them survived. This is a major issue. It is one of the reasons we have gone away from group homes for children. And I know this, and to some extent, this still kind of exists. We do still have the state hospital. We have hospitalizations that can occur in residential treatment centers. However, they're now what? Time limited. It's not like it used to be in the past. You could just put somebody into a hospital and they were there and that was it. So we are moving more in that direction. But yes, rearing in unusual settings can be very, very detrimental to a child. It's one of the reasons why even the children's shelter, who usually does pretty good work, when they're in there, we're working to get them out as soon as possible. Get them into a home. Okay, number D. The care in criterion C is presumed to be responsible for the disturbed behavior in criterion A. This is a big issue, okay? If you have a child that is just simply oppositional and defiant, and it's just because they just want their way all the time, they're probably not going to fit into an attachment disorder diagnosis. Okay? So what they're saying here is in order to have an attachment diagnosis, we have to have severe abuse and neglect. The criteria are not met for autism spectrum disorder. Now, like I said earlier, I understand that's changing significantly too. I'm going to be honest, I've looked at that as well. I actually like the changes for the autism spectrum disorder. And even though Asperger's has disappeared out of that, it's still, in a sense, covered in the new criterion. Maybe at some point I can do a presentation about that as well. Excuse me. This is another big issue because a lot of children with autism also may have Fragile X. That is the one medical diagnosis that seems to be closely related to autism spectrum disorder, is Fragile X. So we may have other things that are going on with a child with autism, as well as one of the new changes in the DSM is autism has its own category now called neurodevelopmental disorders, okay, which is also going to include ADHD. Okay. F, the disturbance is evident before age 5 years. Now, this is mainly because this is what research indicates to us. That about 5 seems to be the cutoff. However, my own practice kind of indicates to me, I think we need to do more research on this. I see lots of adults and lots of older children who are maybe abused or neglected later in life that at least have similarities to this. So I think we need to do more research. But at the moment, the DSM is saying cutoff is 5 years. Okay, so if these symptoms are not present before age 5, you're probably not going to give the child a diagnosis of attachment. The child has a developmental age of at least 9 months. Once again, another major issue. Because what if the baby is born sick? What if it's a fussy baby? Okay, there are all kinds of potentially mitigating issues here. Specify. 1, persistent. The order has been present for, more than 12 months. And 2, specify severity. I want to talk about this one for just a moment. In the past, and one of the examples I gave you a moment ago about the little girl whose caregivers told her a bunch of stuff they didn't need to, her foster mom recently came in and said, hey, I've ordered this book. And it's a book about children with attachment problems. And I always encourage my clients, get stuff like that, but I also like to read it. So I asked her for the author's name and the title, and I looked it up. Well, one of the problems with this book is it's using diagnostic criterion from DSM-5. Okay? That was one of the problems. One of the other problems is that her whole conceptualization is something I've heard a lot, which I don't really necessarily believe in. That if you have reactive attachment disorder, you're going to grow up to be a serial killer. She actually listed out people with attachment disorders were Adolf Hitler, Ted Bundy, several other serial killers, just evil people. So her whole prognosis was that if you have an attachment disorder, you're doomed. You're headed to prison. I strongly disagree with this. Especially if we can get children in for treatment early, this is a very workable and treatable diagnosis. These problems, the children can't overcome them. The caregivers can help them to overcome these problems. I have a lot of success with this in my practice. Disinhibited social engagement disorder. That's a mouthful, isn't it? I haven't seen yet that we're going to go to DSED yet, or DSED, although I suspect that is probably coming because this is a rather long title. But it is a new diagnosis developed for inclusion in the DSM-5. What is disinhibited social engagement disorder? Well, to some extent, disinhibited social engagement disorder is the opposite of reactive attachment disorder in the presentation of it. Okay? So, we are still going to have some of the same attachment problems, but here's the significant difference. A pattern of behavior in which a child actively approaches and interacts with unfamiliar adults and exhibits at least two of the following: reduced or absent reticence in approaching and interacting with unfamiliar adults, overly familiar verbal or physical behavior that is not consistent with culturally sanctioned or age-appropriate social boundaries, diminished, absent checking back with adult caregivers after venturing away, even in unfamiliar settings, willingness to go off with an unfamiliar adult with minimal or no hesitation. How many of y'all have heard this from caregivers, that the child will just go walk up to anybody? I've had numerous cases over the years where the caregivers will go, we were in Walmart the other day, and they just walked up to this person and said, will you be my daddy? Will you be my mommy? Very, very often, children who have this tendency when they come into my office, within 5 minutes of meeting me, they're latched on right here already. There are no boundaries. They're just not there. Excuse me. Of course, this is a very dangerous thing because, yes, these are also the kids that will not think before running off in Walmart. You're over here checking out the green beans, and they're over on the other side of the store checking out Batman. Okay? They just don't have that sense of danger. When I screen my children, when they come in with the questions I have on my questionnaire is, does your child have a sense of danger? Does your child have a sense of boundaries? What are their boundaries like? Because when we're working with traumatized children or children with attachment problems or both, these are very important questions to answer up front. It will tell us a whole lot.